Thank you very much, Teresa. This is a very kind introduction. I'm very pleased indeed to be here. This is my first time in Chicago, and being among a group like you where everybody is interested in the same thing as I am is very stimulating indeed. And coming from a country like Denmark, which is very far to the north, where the light is rapidly disappearing, just the sheer fact of having the possibility to run along Lake Michigan is absolutely a pleasure. So I do enjoy being here. My title is Efficacy and Safety of Transplanting Frozen Thawed Ovarian Human Tissue. And what you see as a background here is the ovary, one ovary from a 12-year-old girl, which is just about to go in the cryotank, and this has been prepared. And I think that this just starts as to show you what we are doing, and what is most important is to make these slices very thin. I think that the take-home message of my presentation today will be that the fertility of frozen thawed ovarian tissue is indeed okay, but we can improve this a lot. And I think that there's a huge potential for anyone who is in this field to do something to optimize this process. We are certainly not there. This is indeed early days. What I do think is, which has been most surprising to me, is that this tissue is indeed lasting a lot longer than we expected. And I'm now trying to enforce the thinking that the hormonal factory of the ovary, the follicle, is actually very well preserved, and we have a huge potential. The tissue lasts a lot longer than we expect, and we have a huge potential to explore the endocrine, the estrogen and estrogen produced by the follicle in a number of cases, and I would like to emphasize this during my talk today. So let's have a look here. So here in America, you usually have a disclosure slide, and I'll do this also. We don't normally do that in Europe, but I have nothing to declare. But usually when I give speeches in America, it's usually a good idea for me to start to explain that I'm coming from a very small country in Scandinavia, where the healthcare system is indeed very different from America, which you may think, why the heck do they do so much work on this in this little country in Scandinavia? And I can tell you this is because that cryopreservation of ovarian tissue is free of charge. We have hardly any private hospitals, so everything occurs in the public sector. So all patients are treated in the public sector. They don't pay anything for the operation to have the tissue out. They don't pay anything to have the tissue cryopreserved, to have it stored intact for as long as they want. They can have it transplanted free of charge, and they can even have IVF afterwards if they want to. Of course, you'll say, so who pays for that? And of course, dollars doesn't grow on trees in Scandinavia. But you don't want to know how much we pay in tax, but we do pay a heck of a lot. And this is the reason why we have such a huge activity on this. So the whole discussion that you have on how to provide this service and so on, this is non-existent. We have fertility specialists who are educated in this, and they will just see the patients when they're there. So you can see a few pictures from Copenhagen here, and it is pretty cold during winter, as you can see. And this is actually the ocean, where we have lots of ice and so on. And we do have sunrises in Denmark also. It may not be as clear as here, but indeed the sun do go up there. And I would like to put emphasis on the Danish program on cryopreservation today. When we have done a lot of transplantation, I would like to go through that. How long does it last? How well is the tissue functioning? And then, as Teresa alluded to, we have come up with some ideas on that we may actually use this tissue for hormone replacement therapy. And there's some very interesting calculations to go through. And I actually think that we can utilize the stores of follicles a lot more efficient. And it may be interesting in the future. And then we have some very new data on the safety, and indeed I think that this is appropriate to address you with, because this is concerning leukemia, and I think we have actually now starting to see a way through harvesting ovarian tissue from leukemic patients so that we don't have a risk of transplanting the tissue. And indeed the first patient who had leukemia have now received transplantation with ovarian tissue. So there's a lot on the agenda, so we'll just go ahead. We have developed a small method just to stain vital stain living follicles, and this is just pieces of cortex where you can see all the small red dots. That is absolutely living follicles, and it's just very nicely to show you that the outer layer of the ovary doesn't contain any follicles, and then you have this massive concentration of follicles, and as when you move down the slide, you can see that the density decreases, but you can also see that the follicles increase in size. And this is indeed what we want to do. So we just need to isolate that outer layer, and this is the way we preserve the tissue. We have normally one ovary taken out, so half of the ovarian reserve is taken for fertility preservation. We prepare the cortex, you see the upper right-hand picture, and then make them into small pieces, and they are then cryostored in individual ampules so that you can take them out one by one if you want to later on. So this, in short, this is our process. In Denmark, we have organized it like this, that it's only the laboratory that I'm heading who is doing the cryopreservation of the tissue. Everybody else, all the hospitals which treat oncological patients, they have a fertility specialist who will counsel the patient at the hospital. If she do opt to have fertility preservation, the ovary will be operated out at the local hospital. It'll be put in one of, you can see that on the background, in a tube with a medium, and you'll put it in a medium container in ice, and then it'll be transported to our laboratory. It takes 4 to 5 hours, and then we'll be waiting for it and then prepare the tissue so that this is centralized. And then if the patient do want to have a tissue transplanted back, we'll take the tissue and liquid nitrogen to go to the local hospital and do the transplantation at the local hospital. So the patient stays with her local hospital and the tissue moves. And this has indeed turned out to be a viable option for us. And this is a small map of Denmark. I may point out to you that on your upper right-hand side you have Sweden, and at the bottom you have Germany. So this is just this little country, and we receive tissue from various parts of Denmark, and it takes, we normally, the transport is either by domestic plane or a car that is driving, and it takes somewhere between 4 and 6 hours. And indeed, the tissue do withstand that. At one point, we had a problem with the transportation, and it was a girl who was just 6 years old. So we had to leave it until the next morning, and then we did the cryopreservation the next morning. So the tissue was actually 20 hours on ice before it was cryopreserved. And then we have done many transplantations to nude mice. We have probably done that 50 times, 50 different patients to make sure that the tissue survived. We did that with this patient also. And as you see, there's 4 weeks after transplantation under the skin of this skid mouse, there's loads of follicles in there. And if you do notice, you can actually see you can see that this is actually blood vessels, and you see small red blood cells in there, and this is exactly how follicles start to grow. They secrete angiogenic factors, attract blood vessels, and then they start to get hormones. So indeed you can do that, and this is the way many European countries are now starting a program like this. And indeed they do this in Germany, where they operate in a local hospital, and then they put it on ice and ship it overnight to the laboratory where the cryopreservation is taking place, and they have babies coming out of this now. As we have discussed, we are approved by the authorities. We have regular inspections, and we have hundreds of pages of standard operation procedures which the authorities want us to do, and we do have that. So we are approved according to the EU Tissue Directive, which means that we may actually collect tissue from all the other European countries. This is our activity over the years. We started in 1999. You can see in 2011 we are doing around 70 cases per year. We are around 5 million inhabitants in Denmark, so it's around 13 to 15 cases per million inhabitants per year. And I don't think we have covered the whole. We probably have covered 75% of the patients who may benefit from this. So this is probably what it is when it's free of charge, at least. This is the different diagnoses that we have used, and they probably reflect very well what we have seen during this conference, that of course the breast cancer patients are the most abundant, and Hodgkin and non-Hodgkin leukemia, and all the malignant diseases. But we are now starting to see Turner syndrome patients, if they have a mosaicism and they still actually have ovarian function when they reach puberty. This is also an option, and there's various others. So this is I think that the difficult part is actually to have all the doctors in these different departments to know that this is an option, because a lot of these patients, they actually do run the risk of lose their ovarian function. This is the different age groups and the number of patients in each age group. You can see we have done 22 patients between 0 and 5 years of age. The youngest one was just 5 months old. We have now done 111, which are below the age of 16. But the majority is between 25 and 35, and we normally obtain around 25 pieces of cortex for each individual patient. So this is how it breaks down. I'm trying a new way to represent the children born from this procedure, and I think we are now up to a total of 23 actually. One of them is a twin pregnancy, but you can see we have produced 4 in Denmark. There's 7 from Belgium in 2 different centers, 1 in Italy, 2 in France, 2 in Spain, 3 in the United States, and that's German silver to the monozygotic twins where the tissue have been frozen, 1 in Germany and 3 in Israel. And indeed there's more coming, 1 in, at least that I know of at this point in time. There's 1 more from Israel and there's 1 from Japan. So a lot of countries are coming on board in this now. The total experience that we have in Denmark is that we have had 22 women who have been transplanted with frozen sword ovarian tissue a total of 32 times, which means that 10 women have experienced 2 transplantations. And if we only look at those where the tissue was transported on ice before we cryopreserved it, then we have done transplantation to 16 women, a total of 23 times. And I always at this point say that we have not observed any relapse whatsoever by replacing this tissue. And I'll return to that. And this is the diagnoses which reflect more or less the numbers that we are cryopreserving from, but Hodgkin's disease, breast cancer, non-Hodgkin lymphoma, Ewing sarcoma 2, aplastic anemia, cervical cancer, and various others. So this is the diagnosis that these patients had when the tissue was cryopreserved, and this is those who had transplantation. And it's very constant that when we replace this tissue, they all, of course, all have very high postmenopausal levels of gonadotrophins, 80, 90, 100 units of FSH per liter. And over the course of the next 3, 4, 5 months, FSH gradually decreases, and then you come down to premenopausal levels. And we have seen that in each individual case. So it is pretty robust. And of course, this is not fertility. This is hormonal secretion from the follicles. But this is very consistent. And I'm having discussions with Hamish all the time. He's asking me to say, so what's the denominator? How successful are you? And I can tell you that these patients are different. You cannot come up with a number and a denominator for how successful this is, because these patients are very different from IVF patients, which we normally see. These patients are young patients who are menopausal. A lot of them just want their menstrual cycles back, and if they do have the tissue back, and they become a normal woman again, they have had a cancer. They may have a different view of their life. They are not certain if that guy is actually the one that they want to have kids with, and so on. And a lot of them say, oh, well, we'll hang in there for a year or so to see if something happens at home. So they are completely different. And we have done 4 patients just to alleviate menopausal symptoms. They were not interested in becoming pregnant. We have had 4 patients where the tissue have stopped. We have actually had 3 patients where the couple divorced, and we have had our first legal abortion. It was a patient who had the tissue transplanted, who started to work, and everything was beautiful, and then she became pregnant at home, and then she came to us and said, oh, well, I'm in the middle of the process of splitting up with my partner, and any patient in Denmark, when it's before week 12, can go next door to say, take it out, and she did so, and we couldn't do anything about it. So it is very difficult to say how efficient is this. And I think it is very important to realize that they are very different from IVF patients who have had a long history before they finally say, we'll go to the doctor to say, help us. It's just very different. And we have actually just made an interview of all the Danish patients who were transplanted, and some of the remarks we have is having back my menstrual cycles and being a woman again was as good as having my hair back after having completed chemo. So it is very important to them. And when we discuss this, I usually say, well, why are we here? We are here to do something good to the patients, and indeed they do enjoy this and are happy about it. And when we ask all the patients who have not used the tissue but have had tissue in the tank, and that's hundreds, a lot of them make the statement that if nobody had talked to me about this, if nobody had said there's something after your cancer, and we even started to consider that maybe you want to have your fertility after cancer, just the sheer fact that somebody did that when I was facing really harsh chemo and had very difficult decisions to take in my life was a huge comfort to us. So it do help a lot of these women. Just the sheer fact that you consider that there is a life afterwards. They may not die. There's something, and we can help. So I think that you need to take that into consideration. As I told you, we have had 4 children born in Denmark, and you see Stine here. She has had 3 kids, just having 6 pieces of tissue transplanted. She had Ewing sarcoma, and this tissue have now been lasting something like 7 years. She's still having regular menstrual cycles. We have had 1 legal abortion. We have had 2 clinical pregnancies, all from tissue that actually were transported before we cryopreserved it. And then from tissue that we froze immediately, we have had another clinical pregnancy and 2 biochemical pregnancies, which were actually heterotrophic transplants. So this is the overall success in our program, and I don't know how I should present this to Hamish for him to be happy about the efficacy of our program. But anyway, that's what it is. But when we transplant tissue, we may put back 6, 8, 10 pieces of cortex. That may be 1/3 of an ovary, or even more, 40%. But when you look at these women, when they have had the tissue in their regular menstrual cycle, and you look at their AMH, it is very low. So we don't have a lot of follicles that survive the procedure. So they may have regular menstrual cycles, but we don't have a huge selection of follicles to choose from. And I think that that's one of the main reasons for this tissue not to be as effective as if you look at normal women. So they do not have the same fertility as normal women. And indeed, there's room for improvement here, absolutely. But if you look at it, and if you take out oocytes and look at it, this is just the different studies. You can just focus on the bottom line. You can see that we have, when we published this year in fertility and sterility, we could find 150 oocytes retrieved. Only 41 of them were actually fertilized and transferred, and it's just resulted in 5 pregnancies. So the oocytes are not as good. The follicles that we have in this tissue is not as good as you normally see. And I don't think that they have had cryo injury. I just think that the selection of follicles is poorer, and we do get all the follicles that would otherwise just have been selected off. But it lasts a long time. I'm just taking out a few examples here. The first row is the first woman that we transplanted. You can see she had 6 pieces transplanted. She had Hodgkin's disease. It lasted for 56 months, stopped working. She had another 12 pieces transplanted. It worked for 25 months and stopped working. She is now in her mid-40s and do not have a partner. Although she still has 15 pieces in the tank, she's saying, oh, I'm happy about it. I'm in my mid-40s now. I don't need it. The next patient have had 12 pieces for 54 months, 8 pieces 33 months, and still have 7. She happens to be married to a man who's coming from a culture where the man, by definition, cannot be infertile. He doesn't have any sperm cells in his ejaculate, but they maintain that they want to be pregnant at home. And of course they will not be. But this man he's very proud, and he cannot be infertile by definition. And how do we put this into the equation, Hamish? I mean, it's difficult to say that this is. I know that they will not become pregnant. If you look at row 4, the girl who was 26 at transplantation, she actually underwent 2 transplantations soon after one another, had a baby, and this has now worked for, you can see the second transplant is 75 months. Just last month she had 2 beautiful embryos replaced. She didn't become pregnant. She's now coming back, but it do work for a long time. So I think that what I just want to make sure that you understand at this point is that it's surprisingly long that we have 1 follicle coming up every month. So how do we best preserve fertility and how do we best postpone menopause? There's options here. So I think that I'm trying to convince people it's probably a good idea to take out 1 ovary, to take half of the pool to put in the tank, because then you have both options. You can take them out and then just transplant them slowly, a few at a time, and you can actually avoid the menopausal symptoms. And if you do want to have fertility, you probably need to sort out a huge amount of pieces, 10, 15 pieces of cortex and transplant the whole thing to have a huge pool of follicles. So you have something to choose from and you can stimulate them and you can have more oocytes. So that's at least how we are approaching this now. And then we have used this to induce puberty in a very young girl who had ovarian failure because she had a hefty Ewing sarcoma. She was 9 years old when she came to us in 2004. We took out 1 of her ovaries. We had 10 pieces of cortex frozen. There was a huge amount. These children's ovaries contain thousands and thousands of follicles. She had a very hefty chemo. She had 41 gray of irradiation to her pelvis. So indeed, her uterus and the remaining ovary were absolutely out of follicles. She came back in 2009 when she was 13.5-year-old and said, well, had not entered puberty. So we had this discussion, and then we decided that we could take out 2 pieces, 20% of our ovarian tissue to transplant, just in order for us to create endogenous hormone production. And we did that. And she started to have menstrual cycles, and she actually did go through puberty based on this. And you can see that you can see FSH came down, and she had estradiol. And of course, Hamish and I, we have this discussion all the time. Hamish tells me this tissue is too precious to use for induction of puberty. And my counter-argument is that if we use 20% of the tissue from this young girl, she still have a lot more follicles than any girl at the age of 20 or 25, where we have already seen that it works. So we can easily use those 20% without jeopardizing her fertility chances later on. And on top of that, I understand that if you have endogenous hormone production, then your uterus is developing better. The risk of having a spontaneous abortion later on is indeed reduced. And I think that a young girl like her, she have had cancer. She's not the same as her classmates. And if you can have her to go through puberty alongside all her classmates and experience the same thing, maybe that's a quality of life aspect for her. And so you can do either things. And there's just a lot of people who's now starting to do this. So I'm sure we'll hear a lot more about that in the coming years. So I've already emphasized that several times now, that we have to distinguish between fertility and endogenous hormone production. I think that this is very important, and one of the reasons for doing this is that these endogenous hormone production actually have a lot of other implications. And if you do take out 1 ovary or part an ovary, it doesn't have any consequence. A woman with 1 ovary is as fertile as a woman with 2 ovaries. Of course, she has to go through the operation, but we have done now more than 600 collection of ovaries, and there's been absolutely no side effects. So you can do that without any risk, really. Not a lot, but of course you cannot avoid that there's risk with operations, but it's not a huge one. And you could consider that these women, some of them, if they enter menopause too early, are prone for osteoporosis. They are prone for cardiovascular diseases. Maybe they want to have natural ovarian activity beyond their normal menopause. So there's actually a lot of things here which women actually may want. They may want to postpone their menopause. And we are now discussing that it's also, I think that this is one of the things, now we go totally beyond fertility preservation in cancer. But it's now estimated that in your part of the world, in our part of the world, half of all the girls who are born today, they will become more than 100 years. This means that they'll be more than half their life without ovarian activity. This means that they will be out without estrogens for half their life. This is probably not the way nature designed it in the first place. Of course, we can just provide them with medication, but it may be an alternative to think that if you had ovarian tissue cryopreserved at an earlier stage, you may use that just to keep up endogenous hormone production. And I know this is controversial, but I just think that I'm sure that it is an option. And it will be raised by some of your patients in not too long a distance. There's already people who is coming and talking to me about this. But the interesting thing is, and that is due to Hamish and the work that they have been doing, that is that if you look at the number of follicles that you recruit per cycle, it actually, you can see this curve that they have produced, Tom and Hamish, that you can see when the women do become perimenopausal, you don't require a lot of follicles per cycle. This means that if you sort of try to make these women perimenopausal by just putting back one piece of tissue at a time, you may actually utilize the number of follicles which is in that piece of tissue a lot more efficient than if it was sitting in situ, because the recruitment rate is very much reduced. So it could be that pieces of tissue that you have been putting down when you were young actually may keep you going for a long while when you do get menopausal. So this is, of course, interesting, and at least it's just a consideration at this point. I'm just saying that this may actually be a possibility. I don't advocate for us doing it, but it's something to consider. So if I have just 5 minutes, I'll just go to the safety slides that I have. And of course, we all realize that we may not know if the original cancer is still in the tissue when we transplant it, and we're not sure how safe the procedure is. And it's actually very difficult because the methods we are using, how precise are they? We can use histology, we can use immunohistochemistry, we can use qPCR for markers, and we can put it into immune deficient mice. But each of these specific methods are not 100% sure. The take rate of immune deficient mice is not 100%. We may overlook something. So we actually do not have the ideal methods for evaluating how safe the tissue is. And the pieces we use for grafting, they are not checked. Those which we check for malignant markers is not the one we replace. So we may find nothing, but there's some in the tissue we transplant, or vice versa. So we don't know that. And of course, it's also very much indeed dependent on what type of disease we're talking about and the progression, how advanced is this tissue. And then it may be that we find just a few cells, but how many cells do you need to replace to have the disease coming back? Often, even in cured cancer patients, if you look hard enough, you'll see malignant cells in there, but they don't become sick from it. So how many do we need to replace? We don't know that. So of course, all these questions make us insecure and may do that we do not replace the tissue. One of the approaches that we have done is always to consult the oncologist. They are often they have a pretty good idea on this specific patient, how advanced was she in her disease, do you think there's any risk of transplanting the tissue? We often have a firm answer, go ahead or leave it out, don't do it. So I think that we need to go back and talk to the oncologist about that. I think that the approach that we have been sort of trying out is the last one, to test 1 or 2 random pieces of tissue from series of women with a specific disease, whether or not they requested transplantation. So you take your whole program and say, so how many leukemic patients do you have? You have ethical approval to take out 1 piece of tissue from each of these patients, and then you look, and if you don't find anything there, it's probably, the likelihood of it being safe is increased at least. So, and I think that it's fair to say that at this point in time, at least what I know of is 44 cases where the patient actually had a malignant disease before, and there's no relapse due to the transplant. But in 2 cases, you had a local relapse where, at the original site of the cancer, one in the breast and so on, and that was not the tissue. So at least Hodgkin is now 19 and so on. So evidence is slowly accumulating that apparently this turns out to be safe. Just to show you with leukemia, this is an interesting story, how this has evolved. We made a study in 2010 where we had 37 women with leukemia. We can't use those which are deceased in Denmark. 2 didn't respond, 2 declined. 26 entered the study. And we had 1 or 2 pieces we looked for. We had the pathologists who were looking at these patients involved in this, and they looked, and we did for all different kinds of markers and whatnot, and none of the tissue was found to contain any malignant cells. And then we were actually able, in 8 patients, to look for a molecular marker by qPCR, and here it's very busy, but basically you can see that they did turn out to be positive for the CML. But for those of you who are familiar with qPCR, you can see that the fusion transcripts is the third last column. Where we found that it was positive was 37, 38 rounds of amplification, and this is absolutely at the brink of what you can expect to see. But it was just 1 cycle more than the control, so we said, well, maybe there is a few cells in there. We don't know that. And those which were negative, it actually turned out that this was where the RNA concentration was very low, so maybe it was just the fact of us having not extracted enough RNA. So this, we said, well, we can't transplant this tissue, it may be positive. Then the group from Belgium came around and had done a study where they actually transplanted this to SCID mice, and you can see that they had CML and ALL. And all those mice which were transplanted with ovarian tissue from CML, they didn't develop cancer. But those which had ALL, 5 out of 12 patients did indeed develop cancer. And there you can see that these mice were heavily infected with cancer. So indeed, there was living cells there. So we said, okay, and they concluded, you can't do this, we cannot transplant this, it doesn't work. Then we said, okay, let's try and have a look at our population of leukemic patients. So we had 47 who had been diagnosed with leukemia. 9 were deceased, we couldn't use that. 1 had immigrated from Denmark, and 5 declined to participate, and 7 did not respond. So we had 25 leukemic patients where we had ethical approval to take out 1 piece of cortex. So we did that. We transplanted that to SCID mice for 20 weeks. You can see that on the upper left-hand corner. And then after 20 weeks, we took a lot of different organs out from these mice, the transplant itself, and you can see at the bottom that there were still surviving follicles in this tissue, and then we analyzed it for qPCR. We had the pathologist to look at it, and what happened? Absolutely none of the mice had any sign whatsoever of cancer disease. So this was, of course, in sharp contrast to what they had obtained in Belgium. So what was the reason for this? Well, it turned out that not all of them, but the vast majority of patients in our series, they were in complete remission. So they had had 2 or 3 rounds of chemo. And it do turn out that the chemotherapy that you use to have these patients in remission is not especially gonototoxic. But complete remission means that you don't see malignant cells in circulation, but they're still present in the bone marrow. So indeed, we didn't see that. So this apparently turns out to be a way that if you wait 2 or 3 rounds of chemo, you do get rid of the malignant cells in circulation, and then you can take out the tissue. And we were able to calculate the follicular density in those who had chemo and those who didn't have chemo before, and there were no difference. So this actually do turn out to be a way. And as far as I've heard, this is not in our center, but now the first patient with CML have already been transplanted with frozen stored ovarian tissue. So things happen really fast these years. I'll skip this, I'm running out. I'll just give you, we have done this with Ewing sarcoma and osteo and various other sarcomas as well. Here you will notice that 18 were deceased, so we couldn't use that tissue. 2 were transplanted already, and they have had the tissue now for 7 years and 4 years, and they do not have a relapse, so there wasn't any danger for doing that, and 2 have emigrated. So 16 were participated in this study. We did the same thing. We transplanted the tissue to skip mice for 20 weeks, and we had, there's a specific marker for Ewing sarcoma. We tested that, and here, again, we actually did not see any of the mice catching on having this. So it do turn out that Hamish is showing us pictures where he'd see a little bit of Ewing sarcoma on the ovary. Maybe, I don't know, but of course this is small numbers, and this would just be very interesting if other groups were able to repeat this. Indeed, it may not turn out to be that dangerous. So I hope that the sunrise has just come a little bit in between the columns and that you feel a little bit enlightened. I'll conclude that the ovarian cryopreservation, including transplantation, is now a clinical option. It do restores ovarian function with high efficacy, and it maintains function for a very long time. It do restore fertility, but we can work on this. We can have more follicles survive, and I think that the main focus is now to avoid the huge follicle loss when we do transplantation and try and optimize that, because I think we probably use 2/3 of all the follicles in connection with transplantation. So there's a lot of things to be done there. Safety requires further investigations, but our preliminary results are pretty reassuring. So having said that, I would like to show you our small laboratory in Copenhagen and invite any one of you who comes around that little part of the world to come and see us. Thank you for your attention.
Thank you very much for bringing us this provocative data. It's really a terrific set of experiences. Dr. Gracia.
Amazing talk. Thank you so much. It's incredible to see the wealth of experience that you've had. What do you now feel is the best method for transplant, given your experience? I'm sure you've tried different things.
I think actually that all the children born up until now, except for one, is using the ovary, the remaining ovary. And I think that that's probably the best place. And I think that this is both from the developmental point of view from the follicles, but also for the functioning of the corpus luteum. The corpus luteum is so highly vascularized, and so many things happen there, that if it's not in the ovary, at least the 2 heterotrophic pregnancies we had, we actually probably didn't go to get real pregnancies because the corpus luteum didn't work the right way. We should have stimulated that a lot more. So I think that just using the remaining ovary is probably the best place. Of course, this leaves I always get the question, so do you know if it's the follicles that you transplanted or is the one which is sitting in there? And I don't know. I don't know. But it's probably the best place to put it in.
And then in terms of, I'm sure Sharm does his laparotomies with microsurgery. Most people are doing laparoscopies. Are you decorticating the ovary?
I think it's, yeah, that's a good question. I think that Sherman has the same experience as we have, that when you put in the tissue, it needs a little pressure. If you have something on top of it, when you put it into the remaining ovary, we make small pockets on either side of the ovary and just slide the pieces down there so that the existing cortex is sitting on top of it, and then we stitch it together, so you sort of press it down. Okay. So I think our thinking
and
is,
you're doing that laparoscopically.
This is just sort of facilitating revascularization and so on.
Okay. So that's what you're doing. You're doing the incising.
Yeah, but then if you do it in a subperitoneal pocket, you just make sure that you sort of have a little pressure from so that the tissue is actually firm against the wall.
And then are you transplanting now in all scenarios, given You know, you haven't done any leukemics, but lymphomas,
we
which
haven't
ones
had
are
a
you?
leukemic patient coming back, but we actually have a patient who had, she had ovarian cancer on one ovary. The remaining ovary was looking good, so we had a piece of that, froze that, and she's now coming back and saying, can I have that? And we're saying, we don't really want to do this. But now we have actually spoken to both the oncological consultants who was treating her in the first place. I think it was 1C stage that she had, and they said, go ahead, you can do it. We have had the pathologist who were looking at her in the first place, evaluating the tissue from the contralateral ovary. She says, I don't see anything whatsoever. We have had some of the tissue on a SCID mouse now for 20 weeks, and the pathologists have looked at that and organs and whatnot, and don't see any sign. So we may be forced to take a decision, but and I'm not sure what we're going to do, but maybe she will receive it.
And sorry, last question. I saw on your slide you had patients with BRCA mutations who will ultimately need to get their ovaries out. At least in the States, we recommend prophylactic oophorectomy in those patients. Are you recommending transplant for those?
Well, I mean, the longer it sits in there, the higher the risk. So, I mean, if you do have them out, you lower her risk. If she comes back and tells us, now I'm prepared to be pregnant, we'll replace them and then see if she can become pregnant, and then sort of say, now we go straight for this, and we put all the treatment on top of you to make you pregnant. Right. And when she is pregnant, we'll take it out again.
Right. Okay. Thank you.
Dr. Wallace.
Claus, thanks very much for an excellent talk. So many questions. I just want to explore with you one particular really interesting area, and that is putting this tissue back for pubertal induction. Okay, this is something that I've obviously thought about a lot, and I've got several patients in whom it might have been appropriate. And I still feel very uneasy about it. Uneasy about putting this tissue back into a patient who's got very high FSH. I think your patient was already, 13 when you put the tissue back. And I noticed from the the graph that it didn't last, well, it looked like the FSH was going up again at about 80 weeks, something like that.
It went up after 2 years.
2 years, yeah. So tell me about this puberty, and tell me about the quality of the breast development, and also tell me about the effect that this endogenous tissue had on her growth spurt, because, you know, those are important things about puberty.
No. I think that when we consider this in the long term, you saw that we actually transplanted this tissue to the remaining ovary, which was just the street gonad. There was absolutely no activity in there. And we had planned that beforehand because we knew that this worked when we used adult women. But when we did the operation, the ovary was so small that the tissue actually went right through. We had to make a hole in the remaining ovary. So it wasn't very efficient. The revascularization process was absolutely not optimal in this patient. So I think that this may be one of the reasons why this tissue didn't last that long. At least this was, in hindsight, we wouldn't have done it this way. But indeed, this girl, I don't know the exact figures, but she was followed by the pediatric oncological department, and they were happy about the development of her. Indeed, I don't have the exact figures on how much she, I can get that for you, but it's the patient, the pediatric oncologist and the mother of this girl were indeed happy about it. We had difficulties having them come into the lab to give blood tests, because now we had already solved this, so they didn't, they say, well, you have done this, we don't need to see you anymore. So, yeah, all right.